Good afternoon. On behalf of the DR.NTRUHS University of Health Sciences, I am Dr. Chandrasekhar, Vice Chancellor of the University. And as a part of the program, the webinar this month, we are having a webinar. One of my classmates, Dr. K.V. Rao, who is there in the States for almost 30 years, and his friend, Dr. Robert Rao, has come all the way from United States of America to give a topic that is inside the point of detection, damage control, and defense strategies of drug errors in anesthesia. So, welcome you, sir, particularly Dr. Robert Rao, and my friend Dr. K.V. Rao, and Dr. Surya Prabha will read the biodata of the batchmate Venkateswar Rao, and after that, I think the Dr. K.V. Rao will take as a chairperson for this session. Thank you.
Thank you, sir. Good afternoon, all. Honorable Vice Chancellor, Sir Dr. P. Chandrasekhar, principals, faculty, and students of our affiliated institutions of NTR University of Health Sciences, and our esteemed guest speakers, Dr. Robert Rao, Professor of Anesthesiology from University of Iowa, USA, and Dr. Venkateswar Rao Karupatti, Consultant Anesthesiologist and Integrative Pain Center Consultant from Iowa State of University of USA. A warm welcome to you all, sir. From the University of Health Sciences, we welcome you on the board of research wing of NTR University of Health Sciences. Myself, Dr. M. Lakshmi Surya Prabha, Director of Research and Development from University of Health Sciences. Sir, in the dynamic and complex healthcare environment, effective leadership is a critical and important requirement. Under the able leadership of our Vice Chancellor, Sir Dr. Chandrasekhar, sir, NTR University of Health Sciences has initiated WebEx meetings to strengthen all the institutions through an interactive session with different experts from India and abroad. Today's WebEx meeting is the third such interactive session. First was being conducted on converting thesis into publication by Ms. Natasha Gulati, and second one on technology-driven transformation of medical education by Professor Siddhaya, ex-registrar. And the third being detection, damage control, and defense strategies of drug errors in anesthesia. This is a special topic from Dr. Robert M. Rao, who is a retired professor of anesthesiology from University of Iowa. And Dr. Venkateswar sir is from our fraternity of Andhra Pradesh. He is from Kurnool Medical College. He graduated from Kurnool Medical College in 1977 to 84 and did his MD anesthesiology in Kurnool Medical College, and later he went to USA and he worked at different institutions, and he specialized in obstetrics anesthesia and cardiac anesthesia, pain management and pain related anesthesia techniques. Sir has so many awards for him, like he is a certified Ayurvedic acupuncture practitioner, and he is a co-author of the textbook Dr. Rao's Anesthesia Drug Errors, Above and Beyond Clinician Award from University of Iowa in 2005. There are so many awards are there for Sir Dr. Venkateswar Rao Garu, but he is guiding us related with this topic through chairing the session. And let me hand over the mic to Dr. Venkateswar Rao Garu for reading the biodata of Dr. Rao and continuation of the topic. Thank you.
Thank you very much. I'm really honored and privileged to be here with my friend Dr. Chandrasekhar and Dr. Surya Prabha Garu, and to bring a world expert to our India and share the depth of knowledge he has. It's really a privilege, and it's very difficult to put in words in very short time, but I will try. And Dr. Ra is not one of the experts. He is the world expert in many areas of the anesthesia, and currently he has published the big textbook of anesthesia drug errors, which is a complex subject. Actually, nobody wants to talk to. It's an elephant in the room which affects the whole world, and drug errors is the third most common cause of death. But having said that, having expertise at world-class level in this is not an easy job. And I am so privileged and fortunate to work with him for the last 20 plus years, and that he is involved me in this project later, and given me the co-authorship for this, editing and other things. But to be brief, Dr. Ra is originally born in South Africa. He is a practiced family medicine and surgeon in South Africa for many years, and also had expertise in an emergency medicine. And he also had a master's in preventive health degree. And then he moved on to do anesthesiology and started the Regional Anesthesia Society for South Africa. And he has done worldwide lectures on these topics. And he has developed labs, one of the first labs in United States in 2004 with a pig lab to teach interventional pain management techniques, especially for acute pain and regional anesthesia blocks. He has a website called regional-anesthesia.com, and I can go on and on and on. And he is a superhuman being, and I'm very blessed to know him in my life and be his. He is a mentor and guide, and also a great friend for me. And it will not take too much time. And with that, we'll ask Dr. Ra to address the audience and with his knowledge. And actually, this is only a teaser and a tip of the iceberg you are going to taste. And if you really want, this is the 800-page book, which took probably 6 years to gather the information and write this book, which you cannot just find by Google or AA or anything like that. So with that, without any further ado, I will honorably give the floor to Dr. Ra. Thank you, Dr. Ra, for being here. Please take the floor.
Thank you, my friend. I know my friend by the name of KV. Thank you for your highly exaggerated words. I'm humbled to be here and very honored. And if I walk tall in any degree, I walk on the shoulders of my teachers. And I try to pass on what they taught me. So the big question is, what is an anesthesia drug error and what can we do about it? And I'm going to try to address that today. Could I get, yes, thank you. Everybody who does clinical anesthesia has made a drug administration error.
I'm sorry to interrupt you, sir. Dr. Roy is not visible, sir. We can see definitely the PPT slides. You are occupying. If you let him come to the center, sir, then he will be visible, sir. Yes, sir. If he comes little towards right, then yes. Now it's slightly better now. Now he is visible, sir. Kunchu, kindly come little right, sir. Some more. So he'll be in the center when you're speaking. We can definitely hear you. Yes, sir. Now you are absolutely in center pose, sir. Yes, sir. Perfect, sir. Sorry for bothering you, sir.
Second slide. Second.
Okay, I've got it now. I've given lectures to groups of 300 people, and I've asked the question of the audience, who made a drug error in the last 12 months, or has a best friend who shared the story of their drug error? And 100% of those 300 delegates raised a hand. The most credible number on the risk factor averaged out was that by Webster, and he measured that one error is made in every 133 anesthetics. For some people, that's about one a month. Now, all of us anesthesiologists, we're good people. We have the best intentions. We want to help our patients every day. And human errors are not crimes and should never be treated as crimes. The question I will try to answer in this presentation is why and how do we make anesthesia drug administration errors, and how can we prevent it? Now, the big three high-risk industries where it's well known that a human error kills people is the aviation industry. And we think about the Boeing 737 disasters, where two planes dived under full power vertically into the ground. We think about nuclear power station disasters, where there's a meltdown of the reactor, and we think of the Chernobyl one. And the high-risk industry is anesthesia. And of these three industries, it is by far the most complex and the most dangerous. And in fact, the statistics show that if you undergo an anesthetic, you are 270 times more likely to die than when flying on a Boeing to Europe. Now, the aviation industry has spent billions making aviation safer. So why don't healthcare managers invest in saving anesthesia lives? Certainly in the United States, my present country, we desperately need more physician anesthesiologists so that anesthesiologists can work shorter shifts and lesser hours. We need better working conditions that are conducive to better mental health, and we need more drug handling technology. We know that of drug errors, about 50% are reported to a safety officer, about 30% are recognized by the anesthesiologist and queried and reconsidered by disposing of the wrong ampoules and vials and syringes and the medical records to conceal that error. Then we estimate about 16% of drug errors are not suspected by anyone. That is totally invisible to the system. So what about the consequences of drug errors? The good news is about 75% don't even induce an observable negative consequence. We know that there are temporary consequences in 20% of cases. It might be a brief rise in blood pressure.
May I request the moderator to mute all the other audience? Only after the speaker finishes, you can unmute others. Many people are talking simultaneously, they can't even hear.
As you have all just witnessed, we've had a little human error, no different to that an anesthesiologist does. Exact same story. Well, in 75% of cases, there's no observable consequence. And 20% of drug errors, there's a temporary consequence. It might just be as simple as it takes 20 minutes longer to wake up from anesthesia. But at the end of the day, they go home fine and healthy. In 5%, the patient will die or have a serious permanent injury, such as amputation of a limb or a permanent hemiplegia. Now let's look at the process step of anesthesia or hospital medication administration. Look down the column in the middle. First of all, the doctor decides to administer a drug. That's making a prescription in his head. The doctor then may enter the prescription onto paper or into a computer. Then the drug has to be dispensed, either by self-dispensing straight from a drug storage cabinet or by a pharmacist. Then the drug has to be prepared for administration by putting the pills into a cup or aspirating the drug into a syringe. Finally, the drug gets administered, then the patient gets monitored for a while, appropriate to the drug. Maybe the monitoring is only for 60 seconds, or maybe the monitoring is to only come back 6 hours later to check the patient. In anesthesia, we monitor the patient every minute. Finally, that administration has to be added to the records. Now, if you look to the right of this image, there are 3 people in the general wards of the hospital who participate in this 5 to 8 step process. First of all, you have an internist or a physician who will decide to prescribe, make a paper record. Then the pharmacist will read that prescription and check it, and then dispense the medicines. Invariably, a nurse will administer it and recheck the prescription and finally administer it. When I was a family medicine doctor, the pharmacist would phone me 3 times a year for a gross prescribing error I'd made, or a nurse would phone me 3 times a year also for a gross prescribing error I'd made. Now, if you look to the left in the pink, this is where we all work as anesthesiologists. We work alone in this 7-step process. There's no one who checks on us. And we don't even enter a prescription. It's all in our head. And the first time we make any sort of administrative record is after we've completed everything we've done. If you look to the top of this chart, there's just a small selection of errors that can happen. The person who stocks the drug cart could make an error and put some sort of codeine ampoules into a box that's labeled ondansetron. The second error could be we unintentionally aspirate a wrong drug into a syringe and put the label on that we hadn't intended to put, of the drug we had intended to put in. Sometimes we put the right drug in and we select the wrong label. Another time we've prepared the drug and 2 hours later we pick it up off the anesthesia machine and we pick up the wrong syringe. All of this is because we are working in a situation where we have a bit of mental fog. That fog is caused by tiredness, inebriation. In my clinical experience, I have found that as little as 1 glass of wine affects my cognition the next morning. So I've had a lifetime habit of never drinking alcohol in any amount if I'm scheduled to be working the next day. You can have a work overload. You're having to work an 18-hour day. You can have cognitive overload. You're just getting too many people all talking to you at the same time. And then anxiety can also cause you mental fog. You can be angry. You can be depressed. Happiest people make least mistakes. Then laid on top of this, you may be exposed to the need to multitask or experience a distraction. At the end of the day, that all adds up to a syringe with the wrong label and a drug error. It's been said there are 6 failures in anesthesia drug making. The one is you did not read the box. 2, you did not read the ampoule. 3, you did not read the label on the syringe. And you may fail to sub-vocalize the drug's name. That's possibly a word you've never heard of before, sub-vocalize. I will explain that a bit later. And you may also fail to lock your eyes onto the label. And I will explain to you later why that is important. On very rare occasions, the manufacturer makes an error and packages the vials with the wrong syringe, with the wrong chemical. In the United States, the FDA recalls about 20 drugs per year because of a box labeling error or a vial packing error. Now, I must admit, I think it's rare in anesthesia. I don't know of a single case ever in anesthesia, but that doesn't mean it couldn't occur. So we do have to think about that. Now, here are 4 pathways that a wrong injected drug could follow. If you look at that left yellow box at the top, wrong drug may be injected. You come down path A, there's no bad patient outcome. The drug that had been intended to be injected is written into the records. In other words, the error is concealed. So in the end, the patient is fine, the drug error is concealed, and it's forever undiscoverable. If you take the next path coming down, there is a bad patient outcome, an adverse event following the wrong drug injection. If we follow down the pink path to path B, the drug that was intended to be injected is recorded. So the error is accidentally and unintentionally concealed. I suspect that happens more than we can measure. So the true cause of a bad patient outcome is unknown, and no one will blame the anesthesiologist. The next possibility is, moving back to the middle and the top of this diagram, that drug error can be discovered, usually by the anesthesiologist. Now, look to the right of that. He will fear facing criminal charges if the patient dies. He will fear being fired and job loss, with loss of income and the means to feed his children and his wife. He will fear being sued. And in the United States, if you get a malpractice award against you, you're very lucky if it's under $10 million. So there's a lot of motivation to intentionally conceal drug errors. Because of that, we lose data, and we can never reach the bottom of path D, how to avoid anesthesia drug errors. So I want to emphasize that it's a big priority to improve drug safety is that every error can be reported, so it can be analyzed, so we can improve the systems that surround the anesthesiologist. So that brings us back to the blue boxes towards the bottom of the picture. We want to work in a no-blame culture where institutional incident reports and patient safety discussions are protected from discovery by lawyers. Ideally, only the safety officer should know the reporting anesthesiologist's name, and the head of department should not even know who made the reports. He should only get the summary of the report. So part C is the ideal. I've never practiced in such a system, but I wish I had.
Co-host with the names are moving. Yes. Santosh Kumar.
Sir, is your lecture over, sir?
No.
Because I can hear so many people speaking in between.
Anjali?
Sir,
Which screen, sir?
That middle one.
This one.
Yes. Okay, I'll take us further. So I'm going to talk now in more detail about anesthesia, medication, administration, process errors. That abbreviation is AMAP, and I'll be using it a few times throughout this lecture. The commonest errors, errors of wrong dose or wrong infusion rates are ignorance errors, and they can largely be prevented by continuing medical education of anesthesiologists and providing standardized dose charts as for references in the operating room on how to dilute unusual drugs or dilute drugs for infusion. Most AMAP errors, however, occur during the automated multi-step tasks that we follow every day when we practice clinical anesthesia. And the main errors are injecting the wrong drug or injecting a drug into the wrong route. So the AMAP process is very vulnerable to worker distraction, multitasking, and fatigue. The AMAP process is long and complex. It can last 30 seconds, or it might last 6 hours from the time you prepare the drug to the time you finally administer it. And we have no pharmacists or nurses double checking us while we work. And lastly, we use the most dangerous drugs in medicine. Countries that execute murderers chemically, the chemicals they use are anesthesia drugs. Each process step in the AMAP process is the cue to the correct following step. If you're subjected to a forced time pause, a distraction, or an interruption between steps, you can drop the preceding step from your short-term memory. That's the cue. So when you turn back to what you were doing and you restart the AMAP process, it is possible to skip the step that you would have done, such as reading a label. Now, if there's already a wrong error, you won't discover it. And this is where a wrong drug can get selected for administration, or you might just inject down the wrong route, down a central line, down an epidural catheter instead of a central line, or you may apply a wrong label to a syringe, and then at the end of the case, pick up that syringe and inject the wrong drug. So now we need to understand a bit about memory. Long-term memory lasts lifelong. It starts accumulating from about the age of 5 onwards, and it needs a cue to be recalled. I've occasionally walked through town and had a patient greet me, and I cannot remember them, because I'm seeing them vertical, not horizontal, and I'm seeing them in different clothing. So I need to chat to them a bit, just to say, just remind me, what did I do for you? What was your surgery? And then suddenly something unique will trigger my memory, and I can recall that patient, all the hobbies, where they lived, what his father did in town. So you need a cue. There are two kinds of memory. The one we call explicit, that's the one that needs conscious recall with a cue, and then implicit long-term memory, which is subconscious, and it's typical of bicycle riding skills. You may not have been on a bicycle for 20 years, and if you get on one, you might wobble for 1 meter's ride, and then suddenly you're riding with the expertise you had 20 years ago. Implicit long-term memory. The big one we need to know more about is short-term memory. It only lasts 30 seconds, and you can only store 4 to 7 items in that memory. And any new item that's added to that memory by a distraction will displace 1 or 2 of the old items completely out your memory. There's a thing called working memory, which is involved in decision processes, and it's a variant of short-term memory. And then there's something called prospective memory. It's the memory to perform the next task. So it needs memory of the preceding task to cue its action. And this is the big center point of where all anesthesia drug errors happen, following a distraction. Cognitive errors have been classified into two types, so-called first and second. First cognitive errors have a faulty thought process, like you are holding in your head a so-called confirmation bias. And this is where you're only seeking information to confirm a desired fact. Patients are very prone to this. An example for us is you read the drug label with a high expectation of what it should be. You know what you're looking for, that's what you want to, that's the ample you want to find, and that's what you expect to read. If you then glance read that label, you can easily misread it and not recognize it's a different drug to the one you are seeking. But you believe you read the name you expected to read. The second cognitive errors involve a multi-step automated process, like the AMAP process that we're talking about, and errors rise when we unconsciously skip a verification step. So what is the cognitive science of errors? Cognitive science is relatively new. It's barely 20 years old. It's not as precision science as chemistry and pharmacology or pathology, and it's pretty an unknown subject or field outside of anesthesia. And it's time we anesthesiologists learned a lot more about this. Now, cognitive errors are not knowledge errors. Cognitive errors arise when the anesthesiologists are distracted, rushed, fatigued, sleep deprived, and multitasking. One of the multitasks that we do is whole situational awareness, and I want to talk about it for a reason. For example, it requires you to listen the whole time to the surgeon's dialogue. Now, I did that in all my anesthetics. Now, I wasn't listening to exactly what the conversation was. I just wanted to be aware of it in the back of my mind. And I can recall a few times the surgeon suddenly went dead quiet. That caught my attention. I immediately looked at the surgical field and realized the surgeon had severed the inferior vena cava or severed the abdominal aorta. And in his total panic in what he was doing, he was not thinking to inform me. Anyway, I realized it and immediately started acting with all the things I had to do. Situational awareness also requires you be aware of vital sign monitors. Every second, you must be aware of the speed of the beat, the pitch of that beat, and the regularity of that beat. And I can recall many times hearing a change in rate, looking at the monitor, and the number was the same. And then 15 seconds later, the number changed. And I often wondered, how am I hearing the number change before the machine does? Well, the answer is the machine doesn't tell you the heart rate in a second. It tells you the average of a shift in 15-second average. And that is why I hear it first, and then it takes the machine 15 seconds for the average to shift. You need to watch your your ventilator settings, keep checking your vaporizers, check your intravenous fluid flow, your urine output, and correlate all of that. And they all interact. When one changes, the others change. Now, if in the efforts of safety officers to make us practice safer anesthesia, they start burdening us with all kinds of technology. They want us to barcode scan the vial when we pick it up, barcode scan the syringe when we put the label on, barcode scan the syringe again when we're about to inject, fill in forms 6 times with lots of checkboxes. If you overburden the anesthesiologist that way, they will lose situational awareness, and that will lead to bad and belated anesthesia management decisions. So the remedies we apply to making drugs safer under anesthesia must be very ergonomically efficient and not burden the anesthesiologist. With multitasking, there are two types. The first we call concurrent, and that is when we do 2 to 4 tasks simultaneously. We say in parallel. A good example is a professional pianist. He can sit on stage, play a piano, look at the audience, sing a song, and then in his own mind silently think about all his travel detail plans for the next day. I was recently driving a car on a busy highway with a lot of trucks. I was having to weave between the trucks and watch my mirrors. I had a manual gear shift. I was trying to stay within the speed limit and not accelerate too much when overtaking. And one of the songs on my CD in the car appealed to me. So I put it on a repeat cycle and I tried to learn it. I tried to sing along. And on my 6th repeat, I was singing it. Then I started to think about a colleague at work who was a very difficult colleague. And I started to think what our next conversation would be. And in my mind, I was saying what I was going to say, and I was imagining what my colleague would say back. And then it struck me. Oh my goodness. I have 2 verbal processes happening in my brain at the same time. I'm singing aloud and I'm thinking an entirely different thing. This is part of the miracle of the human multitasking ability. We are the only biological creature that can multitask. It's one of the best talents we have. So although I'm presenting it as a bit of a bad thing, it's actually a brilliant human characteristic. To come back to the next type of multitasking, it's called interleaving multitasking. That's when we try to deal with 2 novel, cognitively demanding tasks. It is impossible to do that parallel. So the only way to handle that challenge is you have to keep switching back and forth between the 2 tasks. You work on the one, then the other, on the one, then the other. There's no other alternative. So some people will say multitasking is impossible, and you will read that in textbooks. It's actually a misstatement. Multitasking is absolutely possible and regular and common when we are performing familiar automated tasks like handling anesthesia drugs. Now I want to talk about distractions. They can be external, like an angry surgeon saying to you, "Why haven't you given the antibiotics yet?" Or it can be internal. You're heartbroken, you're feeling depressed, you're angry, and you have these thoughts that keep flooding your mind. They're called ruminating, unhappy, emotional thoughts. Distractions cause 99% of anesthesia drug errors. So if you want to simply reduce errors, tell surgeons to be respectful of anesthesiologists and only to speak to them when they're not busy, and speak politely. That will eliminate external distractions. And then make sure your working staff, your anesthesiologists, are happy, and they will make less errors. So how do we handle distractions that happen during drug handling? My first advice to you, all my friends and colleagues, is always be concerned about making a drug injection error. I made a fair amount in my first 10 years of practice. I was shocked at every one I made. In my second 10 years, I made half as many. I was starting to get better at it. And in my final 10 years of clinical practice, I made no errors because I was so concerned about it. So I encourage you, be focused on the problem. Think about it every day. And then be alert to recognizing a distraction. Most times you don't even realize it. You just carry on what you were doing afterwards and don't even remember being distracted. But try to be cognizant of when it happens and return to your task playing this rule. Pause, what, why, where. Pausing means take a breath. Just immediately inject a drug or aspirate it. Just take a breath. Then ask yourself 3 questions. What drug am I handling? Why am I going to administer it? Where am I going to inject it? If you could force yourself to apply this rule for the rest of your career, you will never make one more drug error. Now that's impossible, but work towards that great goal. Mental fatigue increases error rates, and it's caused by sleep deficits, anger, emotional disturbances. And there are a couple of remedies you can apply for mental fatigue. The one is yawn. Yawn loud. Stretch out and strain your hands as you stretch, and then squat twice. You'd be amazed how much that 10-second little exercise will perk you up at 2 o'clock in the morning. The second thing is sip coffee or take a caffeine tablet. And I used to take cans of coffee into my operating room and put up a straw behind my mask and sip my coffee if it was 3 o'clock in the morning. That will not increase surgical sepsis. So it should be officially permitted of anesthesiologists working long and late shifts. The next best thing you can do is take a power nap. You should have a colleague who's available that you can call upon and say, hey, I need a break. And they can come into the operating room, take over your case, and you can walk out to some little rest area, lean back in a chair, and take a snooze for 5 to 10 minutes. You don't want a 30-minute snooze, because you'll wake up a bit sleepy. The magical time is 10 minutes. It's amazing how invigorating it is. I've driven many, many long road trips at night after I'd just flown 36 hours in an aeroplane. And I would stop about every 100 kilometers, take a little power nap on the side of the road. I woke up as fresh as I would wake up on a Sunday morning after sleeping late. The next thing is your work managers should ensure that you never work longer than a 13-hour shift, because you're so much more at risk of making an error after that. Pilots who have a safer job than us never fly an aeroplane for 13 consecutive hours. If you fly that 17-hour flight from Hong Kong to Chicago, as I will be when I go home in a few days' time, there's 2 pilots in the cockpit for a reason. And once they've achieved takeoff and they're at cruising altitude, one of them may leave the cockpit, go and chat to a hostess. He can go to the restroom. He can have a little cup of coffee. And then about every 3 hours, they switch being pilot and control. And there's a reason for that, having those 2 pilots. It adds to aviation safety. The next thing is you should never work more than 48 hours a week. When I first read this, I laughed. Now, this is an aviation standard. It's the law in some countries for passenger commercial airlines. And it's been studied in simulation. In my crazy job, I had to work 100-hour weeks. It's ridiculous. It's not conducive to anesthesia safety. Now, I want to tell you a little bit about reading physiology. There's nothing in any anesthesia text about this that is credible. I got this from studies on advertising. People have studied how to put up posters that will catch people's eyes and that they read the right words and ultimately buy the product that they're trying to promote. I'm speaking now at about 150 words a minute. If you speed read, you read at a rate of about 900 words a minute. Reading normally slowly is up to about 200 words a minute. So spoken words can be detected in electromyogram signals in your tongue and lips and in brain EEG signals. And those precise electrophysiological signals identically replicate the word that generated those signals. And it's possible to train computers to read those signals and create synthetic speech that matches yours. And there are people who are quadriplegics who've been trained to think. They put EEG needles into their heads, and they can get, and you've got to train the computer too, they can get that quadriplegic to speak just by thinking words. Now, we don't always generate EMG signals and EEG signals. Sometimes we're just thinking lightly and we imagine words, and they do not generate EEG and EMG signals. And it's when we are glance reading in a rush, and you're looking sideways at a syringe, and we do not generate those signals, that's when we misread a syringe. So we've got to find a way to force us to generate those signals, and it's called sub-vocalization. Now, the way to sub-vocalize, theoretically, is just to speak normally, as I am now. The term more popularly used to say whispering. Now, you can whisper silently, but you will be moving your lips. Or you can just whisper as I'm going to do now. And that's the way to do it. Now, don't worry if everybody around you thinks you're an idiot because you talk to yourself when you're anesthetizing a patient. You are a genius. You're saving lives. But that process will partly force you to cognitively read the label. And then there's a second trick, which I'm going to tell you about. I'll come to it. So what is cognitive reading? It's a conscious process targeting a printed word with no expectation of what the word is, and you use your central retina to read, and you read it 100% accurately. Glance reading is a hasty subconscious form of speed reading, so you're probably reading at a rate of 300-400 words a minute, with a strong expectation of what the word is, and you recognize the word by its approximate shape, linked to the associated artifact, like maybe the size and color of the vial, and you tend to use your lateral retina. I've been amazed in my journey in writing this book to discover I can have words on a piece of paper about where my hand is next to my face. If you can see me, my hand is nearly 90 degrees from my central retina. It's possible to recognize some words there, but you're highly likely to make an error. So we've got to find a way to kill glance reading. And the big thing is glare and whisper. If you have a syringe on your hand, don't look at it sideways with your eyes. Look straight at it and widen your eyes. That's called glaring. And then whisper. So look at it and say, stop. Glare and whisper will make you never misread a syringe or a vial or an ampule ever in your life again. So you've got to work at that hobby, or that habit, I should say. James Reason studied aviation errors a lot. There were many pilots who came into land and forgot to put the wheels down and crashed the belly of the plane into the ground. There was a recent horrible air crash in India, where shortly after takeoff, the power to the engines was cut, and that plane plowed straight back into a building. They still haven't said officially what happened in that accident, but I'm pretty sure one of those two pilots, unintentionally and as innocently as us anesthesiologists made an error, flicked the power switch to the motors and cut them off, and there was not enough time to rescue that situation. The error to happen, each layer of cheese, and of these cereal slices of cheese, must have a hole in it that aligns up with all the other holes for an error to happen. So, for example, the first hole may be, thank you, a drug has been wrongly stored in the box in your anesthesia machine. The second hole may be you got distracted and you failed to read the vial. The third hole may be you're multitasking and you're trying to pump fluid into the patient who's hypertensive, simultaneous to you wanting to inject a vasoconstrictor. So there's a lot of errors that add up for an anesthetic drug error to reach the patient. And things we can do to block a few of the holes is have a second person check the storage box in your anesthesia cart. Some people recommend having a second person check the drugs you are administering. Now, I worked at a high-tier hospital, and we had a lot of critical patients flown in who would be rushed straight from the helicopter to the operating room. And I would put together a team I would have one trainee just managing the volatiles and the drugs. I'd have a second trainee just managing the record keeping. I'd have a third trainee preparing all the extra drugs we need. And then my fourth and fifth trainee would be busy putting in the extra venous lines, the central lines, the arterial lines. But I would stand back and supervise these groups. So we had many, many checks. It's rare to have the opportunity to have so many people. Most of us practice alone. It would be wonderful if we had a permanent second person. I have worked with such a system in South Africa, and it was a standard for me to have a registered nurse spend the whole day with me in the operating room. And you can use it. You just make a habit that she checks everything you do. Of course, that's an expense, and the managers don't want it. So to summarize at this point, anesthesia drug injection errors are complex. They never occur for a single reason. Be concerned about making a drug error every day that you practice, and you will make less errors. After any distraction that you recognize, follow the rule of pause. What, why, where? And when you read any label, glare at it and whisper it. And then the managers, our hospital managers, the safety officers, our departmental heads must ensure that us anesthesiologists are not overworked and that we get rest as if we were aviation pilots. Now, I happen to worked till recently in the state in America of Iowa, where we have the greatest shortage of physicians in the whole of the United States, and the United States, amongst the top 10 first world countries, is the one with the biggest physician shortage. It's shocking that the United States has this problem. We must train more physicians, have more anesthesia trainee physicians, and we need to open up the doors to immigrant physicians. That'll steal them all from India, but it'll certainly solve my homeland in America problem. Nurses and surgeons who work in the operating rooms need to have courses educating them to be respectful of anesthesiologists, but not to provoke them or anger them, and then not to distract them during critical locked cockpit tunnels. The airlines close down the cockpit from communications during landing or takeoff or preparation to take off, except for very limited matters. We in anesthesia should also have safe cockpit time, and it should be the induction of anesthesia when we've got to handle a lot of things and 6 drugs. That's the worst time a surgeon can speak angrily to an anesthesiologist. Thank you all for listening, and I hope you all have a great day. Thank you.
Thank you, Dr. Rao. It's a very enlightening. I heard this lecture before and when we discussed in preparation, but still, every time I hear, I open some areas of the brain myself. So you can imagine this would cause you to reflect upon and think about, our daily practices. We are rushed in living the lives. Just like we don't think about whenever you're getting into the car, we're going to get into an accident. But if you do the statistics, there is a chance that you can get into an accident. But you don't think like that. But it's back of the mind, the preparation is the key. Just like the CPR training, we are taking it to the public. And this is a thing that physicians, I think, need. And if you keep knowing more and more, you will be amazed more and more how you will be prepared. And these are the things back in your mind, in a critical scenario, flash in your brain that can save a life. So I'm not belittling the thing, but that is why this book probably should be there in every department and every anesthesiologist armamentarium, so that somewhere, some operating room some place in the world, a life will be saved. And I will open the floor for some questions, and Dr. Rohan will be happy to answer. Thank you.
Are there any questions or comments or alternate opinions? I'd like to hear them all. Thank you.
Sir, I'm Colonel Pradeep Pindiala, Dr. Pindiala Pradeep from Ashram Medical College. Firstly, hearty congratulations, sir, Dr. Rao. It was very interesting talk. In fact, I requested all my students also to watch it. Sir, in anesthesia practice, drug arrest is bound to happen, occasionally at least. The fast-paced activity and the look-alike ampules. There are so many look-alike ampules like atracurium, noradrenaline, midazolam, heparin, tranexamic acid, and bupivacaine, and succinylcholine, fentanyl, ondansetron. They look alike, and this bound to happen. And the fast pace, it's bound to happen unless there is a proper color coding, labeling, standard drug trace, or barcode scanning. There should be barcode scanning. So your take on that, sir?
I partly heard what you were saying, so I'm going to answer what I think you said, and forgive me if I missed a point. You were asking about barcode scanning. I do think there's a lot of potential in that. There's a company called Codonics who do market in India, who are the leading company with devices. They have a machine where you barcode scan the vial. Immediately, the machine will speak the vial name back to you. It'll tell you what you scanned. At the same time, it'll print the adhesive label for your syringe, and you can design that label however you like. It's been a big fashion to use color coding for labels. There's no evidence that color coding reduces errors, despite it being almost a world standard recommended by all societies. There's a lot of suggestion that it increases drug swaps within a color group. But it is so deeply embedded, we'll never get rid of this color coding of labels. There is, however, something we must add to it. You will cognitively read a label best if it's printed black in all capitals. No tall man lettering, must be in all capitals. This is well studied in the advertising industry, and it must be on a white background that captures your eye. So you can still have a blue label for opiates, but that must be the surrounding. The word must be on a white background in all capitals. Then you can choose 6 drugs that may get red lettering, and choose the 6 that are the most critical in your opinion. Just to mention 2, I would put succinylcholine as my first one. I'd put potassium chloride as my second one, and calcium chloride as my third one. And then we can argue what the next 3 could be. But no more than 6 get red. Other than that, all capitals on white background. Come back to barcode scanning. That label you attach to the syringe, there's something better than a barcode. There's something called an RFID chip. It's that same radio chip that's in your credit card. That can be imprinted in a label, and it can be tiny. Then you can have a RFID chip scanner attached to your wrist, like in a wristwatch.
Yeah, exactly, sir.
Once you have ergonomic systems, so busy with the patient, you just about to inject, just move the syringe past your wrist watch and inject. The moment that sensor reads the RFID chip, it'll speak the name of the drug to you again, automatically enter it into the electronic record, to which you must return later and just add the dose that you administered and verify that you administered. You need to verify it because it's possible you make an error and accidentally move a syringe close to that. That is pretty ergonomic. I know systems where they use a handheld barcode scanner, and you've got to hold it in your hand and scan the sample, scan the syringe again. That is terrible. It's creating too much complexity for the anesthesiologist.
Absolutely, sir.
Situational awareness. Making the drug safe is not the only thing that must be done. The entire anesthetic must be made safe. So the mechanical systems they add in involving barcodes has got to be very anesthesiologist friendly. And the big clever word is ergonomics. It's got to be ergonomically very efficient. I don't work for Codonics, but I do think they are the leading company with this kind of technology. Not the only one, but it's the only one I know of. Did that answer your question?
A beautiful reply, sir. Sir, I wanted to suggest, could they be always, we should keep it handy like Naloxone antidotes, like flumazenil, Sugammadex, and Intralipid. We must have handy all the time in the operation theater. What do you say, sir? You got me, sir? Could you hear me, sir? I said the antidotes should be readily available in case of mishaps like flumazenil, naloxone, Sugammadex, Intralipid in the operation theater all the time, sir. What do you say, sir?
I agree with you. That's basic anesthesia care. That's basic pharmacology. Having all the antidotes for the critical drugs that we inject, having it immediately at hand is very useful. And you can only use them if you recognize your error. If you haven't recognized your error, you won't use it. But that's a good point. Good stocking of operating rooms.
Thank you, sir. Thank you, sir.
Thank
Have
you.
a nice day, sir.
I just want to add to Dr.RUHS, of course. The problem is most of the time, sudden surprise, shocking, adverse event, you don't know what's going on, what the hell is happened, and suddenly the patient is crashing and you're in panic mode. So many times Dr. Ra gives another lecture about wrong intrathecal drugs being given. Tranexamic acid, for example, the patient is convulsing, and there is remedy for it to withdraw the CSF to decrease the toxicity in the intrathecal space. The other famous thing that happens even today in the United States is vincristine versus the leukemia drug where we inject intrathecal. Both look the same, even today, after all this. So there should be a lot of political physician associations working together to get this under control. But that's my little opinion. Thank you.
I'd like to add a comment to that. I've got another whole lecture on how to handle wrong root injections and also how to handle wrong drug injections. A colleague of mine had a patient who he put onto the transport cart, and the patient then, following an injection for ondansetron for nausea, suddenly stopped breathing and had convulsions. My colleague was panicking. I had to abandon my patient, get a nurse to stand by the monitor, and instruct the surgeon to be watching everything, saying, "I'm just next door, but call me back if you need me." And I ran in to help my colleague. He was very upset, and we got the patient intubated. We couldn't find anything wrong, transported the patient to intensive care, and then returned to the operating room. My colleague kept saying, "Rob, what happened? What do you think happened?" So I said, "Well, do you save all your used vials and ampules and syringes till the end of the case?" He said, "Yes, that was my basic training." So we inspected his vials, and we couldn't find an ondansetron ampule that had been opened. But we could find a succinyl choline ampule that he couldn't explain, and it had been opened. So clearly, he'd swapped ondansetron for succinyl choline, and at that hospital, they were identical ampules. So he hadn't read the ampule. That was his error. So we went to the anesthesia cart and we looked in the ondansetron box, and there were 3 more succinyl choline ampules. So that was the first cheese layer with a hole in it. Made the first error and set my colleague up to compound his error. It so turned out that that patient, half an hour later, woke up, was fine. There were no long-term problems. It so turned out that patient was the owner and manager of the hospital. In addition, his company group owns 50 hospitals around the nation. I never told anyone about my colleague's error. He never told anyone. It's our little secret. And my colleague immigrated to New Zealand 4 weeks later to escape the consequences of his nightmare error. Just a story.
Any more questions, please? If there are no questions, let us felicitate our Dr. Robert M. Rao for his excellent speech, and Dr. K.V. Rao sir came all the way from US to give a beautiful lecture in our university. Let us felicitate our guests on behalf of university and our institution.
Can I say one word? Thank you, thank you, thank you. Thank you. My wife was here for the roses.
Thank you very much. We are so honored to be here and humbled, and wish you all the best, and hope you guys learned something today. Thank you.
All for your active participation. Meeting is concluded. Thank you.